afternoon again, everybody. I hope we all had a wonderful lunch. And not too heavy lunch, so that we don't sleep this afternoon. Okay, we're going to continue our series, and then for the first speaker for this afternoon session is Dr. Mohammed Alluwimi. He's the Assistant Professor at the Department of Optometry, College of Applied Medical Sciences, and he's going to be talking about a disease they call the silent thief of sight. So he's speaking on the topic, glaucoma, the hidden threat. Let's welcome Dr. Alluwimi.
Thank you, Dr. Godwin. Good afternoon, everyone. So, talking about glaucoma today, and we'll talk about the threat to the community, the health community in Saudi Arabia. So let's start with the definition of glaucoma, which is a group of chronic, progressive, and potentially blinding optic neuropathies with defects of optic nerve head, retinal nerve fiber layer, and that these two are associated with the visual field changes. So glaucoma is well known as a second leading cause of the blindness worldwide. The global prevalence of glaucoma is 3.54 as of the Thametol at 2014. Glaucoma represents 12.3% of the total causes of the blindness across the world, and in the Middle East, the glaucoma was also found to be the second leading cause to the visual impairment. In Saudi Arabia, the prevalence of glaucoma is 5.7%. So if we go back to this slide, we're looking here at the number of people with glaucoma as we start with the 2013, and the estimated number of people with glaucoma is 76 million. In 2020, 2030 is 95, 2040 is 112, and that's about 40% increase from 2020. As at this point, the study was done in 2001 that mentioned the prevalence of glaucoma is 5.7, is the last study about the prevalence of glaucoma in Saudi Arabia. And this study was only done in a tertiary hospital. That means most of the cases that they saw is a advanced glaucoma. So how about the glaucoma, like moderate or mild glaucoma? We don't know. There is no a national statistic for that. So let's look at, since we don't have available data for the glaucoma statistic, we will look at the risk factors, and we have some information about risk factors in Saudi population. The risk factors of glaucoma is age, family history, intraocular pressure or IOP, large cubs, corneal thickness, trauma. Systemic diseases include sleep apnea, diabetes, hypertension, hypothyroidism, and medications. In Saudi Arabia, we have three important risk factors that we have information, demographic information about them. That's age, diabetes mellitus, and the high blood pressure. If we look at this graph here, so the old traditional thought about the Saudi Arabian population is we have a small percentage of elderly people. However, this has been changing with the time. As you can see, the green line here, or the green trend, in 2015, the percentage of people over 40 who are in the risk of glaucoma has about 18% of the Saudi population. If we go to 2010, this percentage has increased to 20%, and then it's continue increasing until it's getting 25%. As we can see, the young people here, the trend is decreasing, and when we say young people, the people who are younger than 40 years old. I'm saying the older, people older than 40 years because they are in the high risk of glaucoma. Other risks are high blood pressure and diabetic mellitus, and these statistics are found in General Authority for Statistics as in 2018. As we can see, the percentage distribution of Saudi population by chronic disease for those who are older than 65, the highest two chronic diseases are the diabetic mellitus and blood pressure. So once again, we have these risk factors for glaucoma in Saudi population, and we still do not have routine exams. Talking about routine exams for glaucoma, this statistic also from General Authority for Statistics in 2018, only 25 of the population do routine annual medical exam for Saudi population. So that means these only population will come, or 25% will come, and they will have symptoms or complaining about glaucoma. About 75%, they do not do routine exam, so they are not available for glaucoma screening. The cost effectiveness of glaucoma, if you can see, if the glaucoma in stage 0 or 1, that means mild glaucoma, we have low cost for it, for the treatment. As we go up with the stages, like stage 3 and 4, moderate stages, we have higher cost. And then we have the stage 5, which is advanced stage of glaucoma with the highest cost. So that means if we have early detection for the disease, we'll have low cost and effective cost with the treatment. Now, if we look at the statistic or the distribution in the red box here, we can see all these are visual fields, other devices, or office visits. And these cost very low, and we could use these low-cost, effective method to early diagnose glaucoma and then have the detection of the disease at the early stages, and then low cost could be accomplished. So glaucoma is the leading cause of blindness, but it leads to an irreversible blindness. Glaucoma becomes a public concern, the disease that affects the quality of life for daily activities such as driving and reading. There are challenges in terms of diagnosing patients with glaucoma, especially for primary open-angle glaucoma and normal tension glaucoma. And the main reason for these people is that they will have a normal intraocular pressure. So the main sign for having glaucoma is not there. So we need to do some other tests for these people, such as visual field or optic disc evaluation. For acute for acute angle closure glaucoma, patients will have usually come to the clinic with a lot of loss of ganglion cells because the IOP will go up, and then we'll lose a lot of ganglion cells before we detect the loss of vision. Challenges also for the acute angle closure glaucoma include the ability to reduce or stop the progression of the disease. So just a quick review about glaucoma. There is no known mechanism for glaucoma. The traditional thought about it is IOP is high, we'll have the exoplasmic flow affected, then blood perfusion and the blood vessel is abnormal, and then nerve fiber dysfunction and damage, and then what we call, then the last stage is the apoptosis, what we call it in ganglion cells. So what do we really need to reduce the complications of glaucoma in like the community health in Saudi Arabia? So early and accurate diagnosis. It has been suggested that early diagnosis is critical to stop or at least reduce the progression of disease. That also will give you will give the clinicians the idea on how to be aggressive in the treatment. Once again, if you have really bad loss of vision due to glaucoma, that means you will be more aggressive in treatment. That means you will have higher cost. If you detect it early, and then we may have a treatment plan that is not so aggressive, and then we'll have low cost of treatment. So this is just the study that showed the progression could be reduced from 62% to 45% if we implement the treatment based on the early detection of glaucoma. Early diagnosis in primary eye care includes routine fundus exam, routine IOP measurements, evaluation of anterior chamber, visual field screening. I think we do all these in the comprehensive eye exam, except the visual field screening here in Saudi Arabia is not as popular as in the other countries. If we have done all these routine exams, there will be high possibility of effective treatment that will be based on accurate diagnosis. So who are in charge on most of these tests? They are optometrists who should be well trained and who should be well trained to diagnose and manage patients with glaucoma. However, there are clinical challenges that we should be aware of them, and that is the early diagnosis of glaucoma will be very hard to do because of the high between subject variability in patients in normal population, and that gives the effect on the cup to disc ratio and the dryness hemorrhage that could be easily missed by the clinician who look at the disc. And some types of glaucoma, like primary open-angle glaucoma, it's asymptomatic, so it's really hard to do the early detection of glaucoma, and that needs the routine examination to look at the visual field and the structural damage in glaucoma for these people. These are the signs that we can look at in the exam, instrumentations, and I'm saying do not rely on the IOB by using the air puff. It should be by the Goldman. That is more accurate. So here's an example for just the cup disc ratio to just illustrate the rim area that we should look at, and the most common locations are in the inferior and superior temporal, and this will be based on the clinical judgment. This is just examples for, like, if we have the the ratio from the disc to the cup ratio. So there is a traditional thought that isn't rule should be used or could be used in patients with glaucoma. Actually, there is a study that shows only 37% of fundus photograph and 43 of the RNFL profiles will have the isn't rule working with them. Other than that, isn't rule cannot be applied. In the more recent imaging technology, we had the red-free to look at the RNFL damage, the arcuate RNFL damages, and that's because we increased the contrast, and then we could look at the lows to the RNFL bundles. However, this technique could be limited by if we look at the early detection or like the early cases, it's going to be hard to look at them. Like if we look at the superior temporal here, it's a little bit here. We can look at it, but it's hard to judge that's a real damage or not. And then we have the GDX to look at the RNFL bundles that uses the polarization. And then we have the problem of the large contribution by large blood vessels in the superior and inferior discs. And that also will kind of like, will not look at the temporal sectors of the disc. And then we have the, what we call HRT, and that measures the rim area. And once again, this is also limited by high between subject variability. We have the OCT, the most recent technology to look at, and that makes the B scan around the disc, and then we have it flattened out as we can see here, and then it analyzes the data based on these scans. Once again, the green represents the normal range, and you can see the normal range is very high. And that means I could have a patient at the early stages who are gonna stay, who his profile will be in the green bar, and then he is gonna be, or she's gonna be counted as a normal patient or normal participant. This is how the B scan looked. And it's very precise because this is the histology of the cutted retina, and then we have the OCT image here. And now we have also another protocol in the OCT calling ganglion cell symmetry analysis that quantify the ganglion cells at the region of the imaging, and then we have it coming out from the machine. We have the SDOCT, which is much faster than the regular OCT. What's new? So we're looking at the new in the imaging for glaucoma to have the early detection and something working for routine exams. And that's what we call unfast images. And what we see, the light reflectance is the reflectance of the RNFL bundles. And this is from normal eye. And then we can see here the inferior arcuate defect because of the absence of, or not absence, I will say damage to the RNFL bundles. Here are examples, we can look at them, like even a very small or very narrow wedge defect can be looked at. So, what's the future plan for glaucoma screening? Or how could we decrease the impact of glaucoma in society? So, routine exams are essential, looking at the optic nerve head, the RNFL layer thickness analysis and ganglion cell analysis, and visual field screening is important. So if we could have all these together, we could have low-cost effective treatment plan, we could improve the quality of life of patients with glaucoma, we could reduce also the effect of the complication of glaucoma that include the psychological, social, and economical effects. Thank you for listening.
Thank you for the wonderful presentation. We'll take 2 quick questions.
Thank you, Dr. Mohammed, for your presentation. I just want to ask you about what do you think, in your opinion, the best OCT device in diagnosing glaucoma subject? The best OCT technique or device in the market here?
I cannot say. That's going to be a conflict of interest. So, I mean, the newest generation of OCT is the OCT with the highest resolution. And there are different companies who provide this, and each company have their own advantages and disadvantages. Some of them will have like more for educational and institutional uses, and the other ones will have for more clinical, and we can talk under air about it.
Yes?
Yeah, I have a question. So if you're going to have just 1 or 2 tests in your clinic for diagnostic glaucoma, what are they going to be?
Only 2 tests?
Only, like if you have small clinic, you are working in the practice.
Can I buy SDOCT or not?
Not, OCT is not possible.
Well, I would say 1 functional test, like visual field, and 1 structural test, whatever the structural test, but not like the very old ones, like at least red-free, at least.
Okay, just 1 additional one.
I can't hear you.
Okay, if optometrist is screening in the clinic, he may not have these devices in an optical outlet or just for a basic screening. If he could do just optic nerve head evaluation and the symptoms associated, and also a confrontation test, could have been a referral to a secondary or tertiary eye care center.
Right.
Right?
Right, that's right. So with basic instruments could be used, like ophthalmoscope, or as you said, the confrontation test could be done also. That will give you a sign for the visual field, because sometimes you do not need to do the static visual field. You could do the kinetic perimetry to just have where the scotoma is and look at it. I mean, if there is something wrong with the kinetic perimetry, they could be referred to somebody who has static perimetry.
And most of these
And
patients...
I'm sorry, this is a very important point. Like, if you just have a primary finding, you could refer to a tertiary hospital or more advanced clinic.
Thank you, Dr. Alluwimi, for
Thank you.
the wonderful presentation. We continue now, and we're going to have another lecture. The next lecture is going to be given by Dr. Manzoor Qureshi, and he'll be speaking on the topic, retinal screening, its significance for community eye health. Thank you.
You know, the retina is the most important part of the eyeball. And this sensitive retina, I would say this the vital tissue of the eyeball. And my friend said, why you say the retina is a vital tissue of the eyeball? Why not cornea? Why not lens? But I said the lens has been implanted, the cornea has been changed, but the retina not, still not. That's why it's the vital tissue of the eyeball. And we have to take care of this retina. Otherwise, we will get a lot of problems. And you know the nice architecture of the retina who made by our creature, and how they made it, and how they made the barrier. There are two barriers, very important barrier to maintain the integrity of the retina. And these barriers are very important, and we can see the outer retinal barrier and the inner retinal barrier. These are the God-gifted barrier which protect the sensory layer of the retina. And these are the very tight junction, you know, in the RPE, that's called the retinal pigment epithelium. And this tight junction which maintain the integrity of the outer segments of the rods and cone. And rods and cone are the first order neuron. And which maintain the metabolism of the disc of the rods and cones, and the phagocytosis activity and the metabolism takes place. So whenever there's a problem in the RPE, you will having a visual impairment. And this visual impairment lead to cause handicap and lead to cause blindness. Whenever there's an inner retinal barrier, and this barrier are the capillaries, the tiny small capillaries in the retina, which having a maintain the integrity of the sensory layer of retina. And these tiny endothelial cells in the capillaries which maintain the barrier. So the disease which come across to attack, they disturb the barrier and they become sick retina. And how they disturb, what are the problems, the disease which may lead to cause disturb the barrier? And there are common most hidden diseases and chronic progressive diseases which destroying the retina. And this our aim to examine the retina and screen the retina to prevent further damaging to patient come into visual impairment. And you know the outer segments, this is the outer retinal barrier, are the RP. That is very important. And whenever there are IP at the area of macula, they may lead to cause macular degenerations. And Dr. Shahzad already talked about the lifestyle. We have to change our lifestyle to maintain the integrity of the RP. And the capillaries, which are, again, the problem, the tiny capillaries surrounding the macula. When the tiny capillaries and cells is disturbed, the retinal barrier, it will leak to cause macular problems, as well as lead to cause macular diseases. And you know the common diseases which are very common in bird eye, the diabetes mellitus, hypertension, and macular degenerations like AMD, and the glaucoma, as nicely talked by Dr. Alluwimi. And you know, to compare the normal retina and the abnormal retina. So these patients having a diabetes. So when you look the retina, and the first have a look, you can see the earliest signs of the retina and diabetes are the aneurysm, and that we call microaneurysm. And the tiny microaneurysm will attach with the vessels, and you have to compare whether this aneurysm or dot plot hemorrhages. Dot plot hemorrhages are the next sequence after that, the aneurysm is formed. So we have to look at, and there are different techniques. We have to look the retina, how it will affect by this diabetes mellitus and other diseases. And after that, if you neglect the first look of retina in the microaneurysm, then the patient's developing complications. And this complication lead to cause edema in the macula. After that, when you investigate by OCT, you will got a lot of cysts in the macula, and patient is having an impairment of visions. So that Dr. Wali said in the first talk that prevention is better than cure. And we have to prevent, to have a look in the retina if patient's having a problem in early stages. Otherwise, we will having a lot of changes in the retina. And even though we have to prevent this site, but we can't improve the 100% vision if we look at the first view. And like the other disease are hypertension, again the global disease. And when we look the global prospectus of disease, and hypertension is again the problem and lead to cause different stages of grade 1, 2, 3, 4. So you have to look the grade 1, how this artery affect on the vein and lead to cause arteriosclerosis and sheathing and developing. So the first look, when you have the straightening and attenuation of the arteries, when you look the fundus in the first visit, you can say that patient has hypertension. So the retina is a mirror of the soul, and you can see that we can look the retina and you have looked the stages of the changes in the blood vessels. And sometimes the patient's not knowing, and he will not come with a present of visual disability, or sometimes sudden onset of visual loss. And sudden onset of visual loss, it means the patient in the last stage of retinal damages. It lead to cause compression, lead to cause vein occlusion. Maybe a central vein occlusion, maybe a branch vein occlusion. Why central vein, branch vein? Because of there's association of adventitial sheath in the lamina crossa, as well as the artery crosses the vein. The combination of adventitial sheath lead to cause high pressure on artery on the vein, lead to cause vein occlusion. So that's our aim, to screen the retina and have a look to prevent these problems. And the third one is the macular problem, as we call it, AMD. And the worldwide problem and disease that AMD, and this is the problem in the RP. And this is atrophic changes in the RP in case of lots of risk factors are there. That's why the screening is very important of retina, because those who have a high risk factors, to diagnose the early diseases and early signs, to exclude it and prevent it to further future attack of visual impairment. So these are the different presentations of AMD appear as a drusen. And these are drusen which are nothing. These are the lipofuscin, or the dead material in which the RP does not function. They do not have phagocytosis to maintain the integrity of the outer segments of the rods and cone. Then you appear as a drusen. And these are the waste product accumulated in the RP and the Brooks membrane and lead to appear as a drusen. Drusen may be a soft, may be hard. So after that, drusen, if you don't treat it, then lead to cause new vessels formations, because the barrier is disturbed. So the outer barrier of the retina is disturbed, lead to cause new vessels formation. And patient's loss of vision and lead to cause legal blind. So the third one is the glaucoma, the fourth one, that is the glaucoma, which is a highly impact disease and is a slowly chronic degeneration, as Dr. Mohammed illustrated very nicely. And he said the screen is better than cure and prevention is better than cure. So that's why you look the cup with nice and disc. After that, glaucoma, progressive disease, lead to cause notching, cupping, and ischemia, and nerve fiber damage. So these are the different problems you can come across. And the OCT is one of the good tests you can diagnose by different categories. And these are the normal readings, standard normal readings of compare with the abnormal one in different colors. You can diagnose what the stages of the glaucoma, how much damage by these problems. And the screening, retina screening, is our different scopes or different method, techniques. When I was a student, there was only the conventional method. We examine it by ophthalmoscope and slit lamp to look the evolution of the retina. Now the advanced technique developed apart from the OCT, this is called the optical coherence topography, SS system, which are more superior than the old systems. And the digital retinal imaging, which are again another high resolution power to make the image of the retina up to 60 degree or 18% degree of the image of the fundus. And the fundus fluorescent angiography, the fundus picture, you can take it just to take a diagnose how much leaking is there, whether it's local leaking or the diffuse leaking, and the conventional method. But in case of underdeveloped countries, we always rely upon the conventional method, and those who are developed countries, they live on the top of the many stools which are there. So detect the disease before notice the changes of the visions. That is very important to help to prevent the vision loss and the blindness. So applying timely treatment before significant vision loss. This way our aim to screen the retina in a way and prevent the vision loss, particularly those people who are less advised or less seek to go out for the eye health care. So retinal examinations, regular retinal examinations are essential for identifying the retinal diseases. This is very important. And this retinal examination in a very well-equipped hospitals and sophisticated instrument, you don't need to dilate the pupil, because sometimes patients are afraid or lack of community, though they don't need to dilate the pupil, because otherwise they're having a blurring for the couple of days and couple of hours. So that's why the well-equipped instrument or latest instrument need to, without dilation, you have screened out the retina. So key part of community eye care are the people who are high risk. So high risk, there are a lot of high risk, as discussed, covered by different talks. Age is high risk. Smoking is high risk. So there are a lot of risk, and genetics high risk. So those patients having a high risk factors, you have to at least look at the retina. And because one of the study have found, this study, they said the independent risk factors, those who are not attending the eye clinic. So this is the independent risk factors. Because the regular eye clinic attend, they will not develop this eye problem, and they do not develop any visual impairment. So that's why we have to look at it and screen the eye. And that's other way, the VSP network of doctors, those who are having a highly developed countries, so they're having a teamwork of this network. Because they insure the people, and they insure. Yes, okay. Insure the people, and they have look after this, and diabetic patient, hypertension, macular degeneration, and glaucoma. So our aim is, so there are different studies in which the categories are barriers, patient's belief, social attitude, enabling and disabling factors. Patients sometimes believe, oh, this is not a disease, which is not aware about the disease, what the problem and complication of the glaucoma or diabetes or hypertension. Or sometimes patient attitude, they are far away. They don't attend the clinics. Or sometimes they said, these are the clinics for the sick people. We are healthy. And the enabling disabling factors, because they are far away, there's transport problems. So it's our aim to to supply the services for the screening. So retinal screening services is possible to overcome the barrier and our sight saving. And these are the studies which have done by different persons. So moderate and severe vision loss, these are the studies which are done by almost 300 studies by 98 countries. So they found the common major problem of uncorrected refractive error, age-related macular degeneration, cataract, glaucoma, and diabetes. So these are the different instruments, OCT, and this is the imaging. These are the fundus we have, luckily, and that's why the students of our college, they are doing practice to look the fundus skin out. So how do we keep the eyes healthy? To keep the eye healthy is strict follow eye health care of the professionals. So these are the teamwork or OD doctors. They have to look to strict follow the patients, educate how to attend the clinics, how to screen out the retina. Eat balanced diet, exercise, don't smoke, control BP and diabetes, protect eyes from the sun, and get good night's sleep. Prevention is better than cure. Thank you very much.
Thank you, Dr. Manzoor. Please, we have time for just one question. One question. Okay, thank you for saving our time by not asking a question.
Thank you.
Yeah, thank you, Dr. Manzoor. Our next presenter is Dr. Vishak Nair, and he'll be speaking on awareness of diabetic eye disease among diabetic patients. Let's welcome Dr. Vishak.
Thank you, Dr. Waleed. Thank you, Optometry Department. Thank you, Dr. Majid Mofa, and thank you, my dear students, for organizing such a wonderful conference on mark of, World Sight Day, which was on Thursday. And today my topic, it's actually, can you project the topic here, please? Yeah. My topic is basically related to awareness. It's not too much scientific. It's going to be like knowledge and awareness of diabetic eye conditions among type 2 diabetic patients visiting Diabetic Center of Buraida Hospital. So it's more of kind of awareness which we did with the students of OD program, the final year students of OD program. And this year on mark of World Sight Day, we focus mainly on diabetic eye disease. And IOF, WCO, International Diabetic Federation, and IAPB jointly now issued a statement like strengthening the health systems to manage diabetic eye disease, integrated care for diabetes and eye health. So this was a common statement which was issued by IDF, WCO, and IAPB to strengthen the focus on diabetic eye disease. So, and if you look into the global projections of diabetes, we all know that, it's year by year, diabetes is increasing day by day. So if you look into the global projections, in 2025, they expect around 380 millions by 2025. And if you look into the Middle East scenario, 24.5 million is going to be 44.5 million in another, in 2025. So this is the projections which is given by IDF, International Diabetic Federation. And if you especially look into Saudi Arabian scenario, we are actually ranked 6th in diabetes population. So if you look into Qassim, we are in Qassim now. If you look into Qassim, you can see 20, how much it is, 20, can you see? So 20, yeah, around 25%, is the prevalence of diabetes in adults in Qassim. And this awareness is something very, very important. Because we as clinicians, we follow, we see the patients, we do a lot of clinical examination, but unfortunately, we don't, give that much amount of awareness to patients how to take care of their eyes. So we thought of doing that, with the help of optometry final year students in different hospitals, and we took Buraida Central Hospital as the place of study. So as we all know, Dr. Manzoor covered well, the impact of diabetes in the whole body. So if you look into the impact of diabetes, you may be wondering why I kept diabetic retinopathy, cataract, and glaucoma there. Dr. Manzoor has covered diabetic retinopathy. Dr. Mohammed Alluwimi has covered about glaucoma. But here, it is not the regular glaucoma what you see in clinics with diabetes. It is a secondary glaucoma. You know about neovascular secondary glaucoma. The patient developed secondary glaucoma because of diabetes, and it's cataract. It's basically because of the metabolic changes that happens in the human lens, which causes diabetic cataract. And the diabetic cataract tend to happen like it's not like age related. It happens earlier in life. And diabetic retinopathy, as you know, it is microangiopathy, which can affect individual blood vessels, arteries, and veins. Okay, and other things about stroke, heart attack, nephropathy. And like diabetic food, these are the other things which we need to think about it. So as we celebrate World Sight Day on 14th of this year, 2nd of Thursday, every October we celebrate World Sight Day. Exactly after 1 month, we celebrate something which is World Diabetic Day, which is 14th of November. And IDF used to issue some kind of awareness programs and posters with regard to people with diabetic loss to increase awareness about diabetes. And if you look into the strategies of how to make more of awareness in diabetes, I found this very effective, which was actually by the Singapore Ministry of Health. And the fourth one, if you say, public education to raise awareness. This is something very important which you need to do. We know healthy living, early screening, better disease management, public education, and stakeholder engagement. So all this combinedly would make it more effective, the diabetic awareness more effective. You could see some Arabic script which I can't read for you, but still, this type of awareness programs can leaflets to public and if you look into the impact of diabetes on vision, I always feel, especially when you educate your diabetic patient about vision-related changes, I just want to focus on one thing, like Dr. Manzoor has showed you some, has demonstrated here, like diabetes, retinopathy stages and all these things. But there is something which is diabetic macular edema, where people tend to, they think that it's a floater which comes in front of the eye, but it's basically a macular edema. And they think that they move their eyes, they see a central scotoma, but it's basically a macular edema there. So it's better you demonstrate your patients with diabetes with such pictures so that they understand what can happen to your visual field with diabetic retinopathy, with diabetic macular edema, diabetic cataract, or with a glaucoma. So it's always better when awareness program you need to show this type of posters to make them understand. And I know that it's only awareness is something which is not very important. If you do awareness, it's not the only thing what you can do for diabetes. So it is a multi-strategic approach which you need to do for awareness. And this is just a scenario which I took from a model which we do it in India, Aravind Eye Care System, which is considered to be the biggest eye care systems in the world, or in Asia, I will say. They use this type of approach in strategy in awareness of diabetes to make, to decrease the diabetic complications, like, starting with an epidemiology, with a survey, community outreach camp, mobile screening units, awareness creation, rural remote screening centers, tertiary services, and, training and research. So collectively, it is collectively which will help the diabetic to reduce diabetic eye complications. So if you look into literature review about Saudi Arabia, there are a lot of literature which says about the prevalence incidence of diabetes in Saudi Arabia. And this is one study which is supported by Ministry of Health. And they say that, it is increasing year by year. They could see a marked increase in the diabetes mellitus year by year. And even, if you look through articles which is related to diabetic eye complications or diabetic retinopathy, they say, if you read the last conclusion here, although a large proportion of diabetics in Saudi Arabia are aware about diabetes, but however, no little knowledge of risk factors and prevention. So this is something which gives you a space to do more of research. So there is a need for increasing this awareness in order to decrease the number of cases of blindness resulting in diabetic retinopathy in Saudi Arabia. So this type of research supports your thought of increasing awareness program. So this was our aim of the study. We did it in Buraida Central Hospital. The aim of the study was to increase awareness and to also know the knowledge of diabetic, and also to make an intervention. Usually, what we do in awareness study, we just take the awareness, take it with you, publish an article and leave it. We don't think about the stakeholders. We don't think about that patients. Okay, they are left with that much of knowledge. We don't improve their knowledge anyhow, yes or no? So we thought of doing an intervention to improve their knowledge on diabetic eye disease. So for that, what we did a prospective hospital-based cross-sectional study with questionnaires, and then diabetic eye conditions with an intervention, and we did it with valid questionnaire, information booklets, and these were the excluded patient, and it was in Buraida Central Hospital. I'm just rushing because I know there is less time. So this was a kind of leaflet which we used, and it was a health education. Especially when you do health education, you talk. And please understand, the study what we did, it was not in an eye department, it was not in a public space. We did it in a Buraida Hospital diabetic eye center, diabetic center. It was a diabetic center where only diabetics used to. So there was public education, health education with the help of this type of pamphlets by final year OD students. So they did this study. I hope most of you can read Arabic and you can, okay? So it talks about, about the ocular changes and what needs to be done. I did not put every slide, the pamphlet here, but these are some samples for just demonstrating you. And in the results, once we did the study with a questionnaire, we got some interesting information. The best thing what I found was everyone was aware that they should do an eye examination yearly. We asked, whether you will do it yearly, 2 yearly, every 6 months, or, only when the vision is affected. But most of them, you could say that, yearly. 38% of them told that, you should do an yearly checkup, which was encouraging for me. And when I went to the next thing, where did you think what is the biggest barrier for not getting your eye checkup? There were some people who never went for an eye checkup to any doctor or any hospital. And we asked, what was the main barrier for not going to a health center? And unfortunately, most of them, and this is, it was lack of time. And most of them told, no, I did not get, lack of time was the main thing. And the second one was, if you see, time limitation was 51%. And the second one was, if you see, discovering something bad in my eyes. They thought, if I visit a doctor, my eyes may be good, but he will find something new and he will try to, exaggerate the situation. So, which composed of around, and you may see the percentage is slightly high because we gave them 2 options to, that's why the percentage is higher here. Okay? So this was the percentage. And we asked another question, how did you come to know about diabetic-related eye complications? Unfortunately, everyone told it is by a doctor. And when we asked, the general practitioner were the main persons to give the information. And then come in the internet, then come the relatives with diabetes. Unfortunately, there was optometrist also there were around, optometrist was around 13% or 14% who gave them information about their eye issue. So this was some comparison before and after awareness. When we did awareness, these are the questions which we asked. Okay, so can individuals with controlled diabetes have eye problems? Most of them thought that it's not the duration of diabetes, it's the control of diabetes which kept their eye secure. But it's the other way around. Like Dr. Manzoor was saying, it's the duration of diabetes which will cause most of the eye problems. It's not the controlling diabetes. Maybe you control diabetes for 20 years, but definitely you are supposed to get some sort of eye-related changes in your eye. Yes or no? So you can see a marked increase in these 2 categories. So are you aware that diabetes affects the retina? Yes, we asked this question and we could see a marked increase here. And most of them, they thought that it was more of ophthalmological, it was more of retinal issues in diabetes. But we as optometrists, we should make them aware that it is not only ophthalmology or retinal checkup which is important. Even wearing your spectacles, maybe you got your spectacles when your A1C level is very high, you got -3, -4, maybe after 3-4 days when the A1C came down or when the blood sugar came down, maybe it can differ. So do you know the power of eye or glasses with the level of sugar? With the level of sugar, it goes up and down. As you know, myopic shift may happen when the blood sugar is high. Hyperopic shift may happen when the sugar is low based on the refractive index changes of the human eye. Okay, so this is another question. Does a diabetic patient need to have an eye checkup? Yeah, this is the same thing which I told you earlier. Do you think when you are in uncontrolled sugar, there is a possibility of getting internal bleeding in the eye? Layman words, sometimes, when you say them about retinopathy or retina or something, they may not understand. That's the reason you see common man language, and it was given in Arabic. Unfortunately, I can't read it. That's why I did not mention here in Arabic. So this was a question which we added. And if you compare the studies here, there are a lot of studies which is done like this sort. But we did something which is, most of the survey was only a survey. They never did an intervention to improve their knowledge about diabetes. So we could improve their knowledge, and if you compare there, 51%, which was very similar like a Maryland study which is in USA. there were around 51% of the population had some ideas about diabetes and eye, which was similar to us, but we could improve their, ideas on diabetic eye disease by doing an intervention, and it came up to 86%. So, which was really good, okay? So, optometrists have both the capacity and responsibility to increase patient awareness about diabetes, facilitate early detection, and assist in eye disease management and treatment. Awareness and knowledge could lead to better understanding and early treatment of diabetic eye complication, thereby reducing visual impairment in Saudi Arabian diabetic population. Okay, and conclusion is information booklet intervention or health education intervention on diabetic eye conditions by final year OD students to type 2 diabetic patients demonstrated a better understanding among patients visiting Buraida Hospital. And this is one website, if you want, you can really download it and read Diabetes and Eye Health, which is from the Diabetic Eye Federation, International Diabetic Eye Federation, which will give you a lot of information about diabetic eye health. Thank you. Thank you.
Thank you, Dr. Vishak, for that illuminating presentation. Before we go on to the next speaker, which happens to be the person talking now, so I'm already speaking, we're going to do a short interval. And in that interval, we're going to invite Dr. Majid Muamfa to present certificates to individuals who are presented. Let's also welcome the head of Department of Optometry, Dr. Walid.
First of all, I would like to thank all the speakers. I would like to thank Dr. Shahzad Naro, our guest speaker. Also, I would like to thank all the students. We are very proud of you. You've been proving yourself very active, very helpful, and I hope that you learned something today. All the lectures today will be included in your exams, the midterm exams. And except this one. Especially this one, okay. So I would like to invite our Dean, Dr. Mohammed Alluwimi, to give a certificate of recognition for our speakers today.
الأستاذ الدكتور يوسف بن حمود الدباسي، الدكتور سليمان الدخيل، دكتور Godwin Ovenseri، دكتور سيف رشيد، دكتور منظور قريشي، دكتور وليد، دكتور فيشاخ نير، دكتور محمد اللويمي، طبعا المقدم ما له شهادة، شيء طبيعي جدا. الدكتور وليد بن محمد الغامدي.
So now we'll return to Dr. Godwin.
Thank you, everybody. I know it's getting late in the day, and some of us are already getting tired. Eyes are beginning to close, but just try and stay awake for a few more minutes, and then we'll be done. And in case you fall asleep, remember this story. In a classroom, the lecture was going on, and then one person slept off. And the teacher was making a statement, and he said, please raise your hand. And that was exactly the same time that the person was sleeping, woke up. And as soon as he woke up, the only thing he heard was, raise your hand, and he raised his finger. I just said, yes, answer the question. Because he was sleeping, he didn't know that a question was asked. And the question was, if you know the answer, please raise up your hand. The person raised up his hand. And he was just waking up from sleep. You can imagine the mess he was in. So please, try not to sleep, okay? So be awake. We're going to be looking at assessment of visual function in patients with low vision. And the idea about this workshop is just to stimulate us, to make us to begin to think about low vision. Now, in the earlier presentation, Dr. Walid asked a question as to how to motivate students to get interested into low vision. And this slide will tend to answer that question, which is my journey into the world of low vision. It started in 1999 when I was in my penultimate year. I was asked to do a presentation on any subject matter in optometry, and I chose to present a topic on electronic magnification system. Now, thereafter, in 2007, I was a lecturer at the University of Cape Coast in Ghana, and we had gone on holidays, and then I returned back from holidays, and my manner is, as soon as I come to school and I resume, I go to the head of the department office to greet him and tell him I'm back. So I got in that Monday morning to say, sir, I'm back from holidays. I just came to greet. Say, hey. As I was stepping out, he said, Godwin, please come. You see, I've been invited. Now, the head of the department was not an optometrist at the time. He said, there's this workshop I was supposed to go to for low vision, but I don't think I can go because I have not prepared anything. I said, where, sir? He said, Ekropo is about 4 hours drive from Cape Coast. And I said, can I go and represent you? He said, but I've not made any presentation. I said, okay, I can do a presentation. I can, between now and tomorrow morning, I can do something. It's okay. Go and prepare your presentation. Bring it to me. Let me look at it. So I walked throughout the night, made that presentation. The presentation was just to look at the role of training institutions on improvement of low vision in their curriculum and all that. So I walked through that night, and that morning I brought it to him. He said, okay, this is good. Go. So I call it, I get crashed into the regional low vision workshop in Ekropo in 2007. So that was my first launch into low vision. Because of this interest, so many other things began to happen. And in between 2010 and 2014, I was the resource person in the National Low Vision Workshop for Eye Care Professionals. Now, like I said in my earlier presentation, before that 2010, we only had 3 facilities where low vision services were being offered. But because of this 5-year workshop that was organized and sponsored by Brian Hode Vision Institute, many other low vision centers were opened up because it was a 2-week intensive training on low vision, and we graduated a lot of people to begin to do low vision. And then in 2013, I was invited to participate in a training workshop in low vision for another 2 weeks in the Okong Society for the Blind. And in 2015, I was invited as an African low vision experts to participate in the International Consensus Conference on Standardization of Visual Rehabilitation. And the outcome of that workshop will be presented in the next slide. And presently, I'm a senior registrar in the Nigerian Postgraduate College of Optometry, Faculty of Low Vision and Rehabilitative Optometry. So now, what has kept me going is a personal interest. And let me quickly tell you, especially for those of us who are students and those of us who are just graduating, to be very frank with you, low vision is not as interesting as contact lens practice. It is not as interesting as, primary care, where you just do your refraction, you put the person in auto-refractor, get your refractive error, put the lenses there, the vision improves to 6s, prescribe, the patient walks out. But this is a little bit more, takes more time. But then the interest you build and the joy of seeing somebody who was led by the hand into your practice, and after 2 hours section with that person, or 3 hours, or even after 2 hours, you said the person to go home, come back another time, maybe 2 days or 2 sessions of assessment, and then this person is now able to read some prints and is able to walk around independently. It's enough motivation to push us to begin to think about low vision. So this was the document that was presented, that was developed after that WHO workshop. It is International Consensus Conference on Vision Rehabilitation Standards, and that standard is available. You can access it at that conference. And that arrow there points to me during the workshop. Now, these individuals I've had occasion to interact with in the course of my low vision surgeon, Professor Ian Bailey, who developed that chart we're looking at, the Logman chart. Professor Jill Keefe, an ophthalmologist from Australia, Azan Minto, a Pakistani optometrist, Dr. Anebri, Professor Palaba, Dr. Babi, and Dr. Imran Khan. So these are individuals that I've had occasion to relate with and interact with in my low vision journey. Now, what is low vision? Somebody said low vision means vision that is low. All right, but that is not what it is. So low vision is a level of visual disability that causes difficulty in carrying out everyday tasks according to Optometry Association of Australia. Now, the WHO defines low vision in 2 ways. One is an epidemiological definition of low vision, and the other one is defining low vision from a service provision point of view. And that service provision point of view also relates to functional aspect, how low vision affects the ability or the individual's ability to function. So the epidemiological definition just look at visual acuity of 618 or worse, and then a visual field of 20 degrees. But in terms of the functional definition, it says, it looks at, instead of defining low vision as a condition, low vision as a condition affects a person. And so you want to look at that division in terms of how it affects a person. So it says, is a person with low vision is one who has impairment of visual functioning, and after treatment or standard refractive correction, has a visual acuity of less than 618 to light perception, or a visual field of 10 degrees from the point of fixation in the better seeing eye, but who uses or potentially is able to use vision for functioning, planning, and execution of tasks. So this person must be one who must have had refractive assessment, okay, or surgical intervention or medical intervention. And after this intervention, there's still residual visual impairment of 618 or worse. Then this person needs to be assessed for low vision. So usually when somebody calls me to say, we have a low vision patient for you, and I say, what we have done? He said the person came, we did the VA, is 660, and then the person we did refraction is not getting it, so this is low vision. That may not necessarily be. So if you do a very good refraction, you might be able to improve the vision beyond that. Now, low vision is seen as, or visual vision is a spectrum ranging from sightedness to blindness. And so that is the spectrum that is presented there, with every individual having different cutoff points or different level. So each of us here will probably be somewhere within this spectrum, ranging from normal vision of 6.6 to 360 and then blindness. Now, I queried that 660 there, which is what is called legal blindness. Now, after this presentation, I don't expect that anybody in this room we misuse the concept of legal blindness. Okay? Now, what is legal blindness? Legal blindness is a level of vision that is specified by individual countries. Okay, a level of visual impairment that is specified by individual countries for the purpose of providing not low vision service, but for the purpose of providing welfare service. Okay, some countries of the world like the US, Canada, Australia, the UK, once you have that visual impairment, you are given certain free things. For instance, you have free transportation, you have access to free library to access low vision devices and all that. And then low vision devices are provided for you free of charge. So to benefit from those freebies, they needed to have a cutoff point. And that cutoff point is normally certified by either an ophthalmologist or an optometrist to say you have this level of vision. And so individual countries have their different cutoff points depending on the resources they have, because if the cutoff point is too low, more people will be accessing, the service. If it is too high, you cut off. So that is a compromise. So because of this, it is not uniform from one country to the other, which is why we call it legal blind, because it is defined by an act. Okay? And for the US, that is the cutoff point is 2020, which is 660. And then the visual acuity cutoff point is there. Now, let's quickly look at this global outlook, which defines the prevalence, and the information is there. 217 million have moderate to severe visual impairment, 36 million people are blind. And of course, when we say blind, it's not necessarily the absence of vision. It is visual acuity, which is worse than 360. And oftentimes, with low vision assessment, this way can be brought from blindness to low vision, and then low vision to some level of impairment. So let us begin to think that for low vision, if you recall that spectrum of blindness that I presented before, low vision intervention is to move people from this end of blindness towards the sighted side. Now, sometimes we may not be able to get this person to move from blindness to sightedness, but we're able to move the person from this level where he is dependent on other persons. Okay, to move around, I need somebody to take me around. But now, I've gone for low vision assessment, I can move around by myself. So you have moved that person from this far point to somewhere here, or so you are moving the person towards the sighted spectrum. Okay? And of course, we know that approximately 80% of all visual impairment globally is considered avoidable. Refractive error, like we have been told, is the leading cause of visual impairment, followed by cataract. These are conditions that are avoidable. And by avoidable, we mean that they are either treatable or preventable. And this is the map that we have. Now, I want to highlight this point here, which states that 89% of visually impaired people live in low and middle income countries. That tells us that poverty is a risk factor for going blind. Categories of visual impairment. Now, up until 2018, if you have a visual acuity of 612, you'll be considered that you have mild visual impairment. Okay? Or, in fact, the word is no or mild visual impairment. But from then on, it has now been regarded as a separate entity. So it is no longer lumped up as no visual impairment. So because of the slight improvement. And of course, like we saw, maybe I'll quickly highlight this. Now, where is it? Okay. From 1990 to 2015, the prevalence of blindness have dropped from 4.58% to 3.38%. So we are making progress. But we need to improve on that progress some more with, public health awareness like this, talking to people about eye care, regular eye exam, and so on and so forth. Now, what is visual function, which is what we're looking at today? What is visual function and what is functional vision? Okay? Now, visual function relates to how the organ of sight, the eyes, functions. Okay? Whereas functional vision talks about how the individual function using the eyes. So when we talk about visual function, we are talking about those tests that assesses the functional capacity of the eye. Tests like visual acuity, contrast, color vision, and so on and so forth. But when we're talking about functional vision, we are looking at how this individual is functioning using the eyes. And so we need to be able to draw the line between these two concepts. So the following visual function tests are normally considered: visual acuity, visual field, contrast sensitivity, color vision, photophobia, stereopsis, diplopia, visual distortion, and visual perceptual difficulties. But for low vision, the first four are quite important, and these are the things we're going to try to discuss this afternoon. Now, we'll start with visual acuity. Visual acuity is the assessment of the finest spatial detail that the system can resolve. It is not ability to see, and I think we need to make that clear, which is why I always say that when you are testing visual acuity in the clinic, especially for low vision patients, don't ask, can you see this? Okay? It's better to ask, what is this? Let the person tells you what he is seeing, not can you see. Now, why don't we use can you see? The person with low vision coming to your clinic more often than not had visited some other clinics and had been told your vision is poor and we can't do anything about it. Okay, or we're just imagining this like this is the best we can get. So he knows that in his mind, I can't see. So when the person comes to your clinic and you are telling this person, what can you see? Can you see this? Can you see this? In his head, he may not voice it out to you, but I have seen individuals in anger and they are telling you, if I can see, I won't come to your clinic. So that is, you also need to understand the psychology of people with low vision. If I can see, I will come here. That's why I'm here. I can't see, that's why I'm here. So you have to say, please look at this. What is this? Okay? So it is not the ability to, it's the ability to tell two things apart. And it's normally measured as a minimum separation distance between two targets so that the individual can tell the targets are separate. Maybe the gap between the letter A, and that is resolution acuity. So in low vision practice, measuring visual acuity often provides the initial insight into the level of functional vision loss, the need for eccentric viewing, and even the type of training that may be required. Now, this person knows that he can't see. And this person has come to your clinic. He was probably led by the hand into your clinic or, felt the wall, to get to sit down. How do you know how much vision this individual has left? Now, let me also quickly mention this, that in low vision, what we are doing in low vision is not to restore vision. It's not to make the person see again. Because we were told that glaucoma leads to irreversible blindness. Okay? So whatever vision that is lost is not what we want to remedy. In low vision, what we are doing is to maximize the residual vision. So the vision that the individual has left, how do we make it bigger? How do we make it more useful to the person? So you must be able to measure the remaining vision that the individual has so that you know what you want to maximize. So what are the objectives of measuring visual acuity? One, to provide baseline information. We want to know where are we now. So that if I eventually make progress, I know we have increased the visual acuity from point A to point B. But if you don't know where you are starting from, you wouldn't know whether you have made progress or not. Two, for calculating magnification requirement. So if a patient can see 660, I want the patient to say 6.6. You can find the fraction of these two distances, and you know what is the expected telescopic calculation you will use to improve the vision. Measuring the effect of disease. So this individual has glaucoma, has cataract, has diabetic retinopathy. How do you know how much damage that thing had caused to the visual function? Okay? By measuring visual acuity, you can tell that, yes, glaucoma has reduced its vision from, say, the normal expected visual acuity is from 6.6. It has now reduced to 6.18, 6.60, and whatnot. Measuring stability of vision and monitoring effect of intervention. It shows you whether this condition is progressively going worse or is getting better because of the intervention. It provides reinforcement. Now, what is reinforcement? This person, like I said, has been told you can't see. And now the person comes to your clinic. He sits down. Now, with appropriate chart, you bring the chart very close to the patient, and you say, please look at this. What is this? And the person is able, maybe for the first time, is able to see the big letter O. He's excited. And oftentimes, what I normally see when I bring those charts close to the person and they're able to read, you will see the smile on their face. Because oftentimes, before now, they have been told, well, we can't improve your vision. You can't see beyond this. So when you make them see something, there is that reinforcement and then that excitement that comes. It means that there is hope for me. I'm not completely blind after all. Now, it established eligibility for social services and benefits for the visually impaired. Like we talked about legal blindness. For you to qualify to access those benefits, you must be certified legally blind. And the cutoff point is a visual acuity cutoff point. And finally, quantifying vision loss for the purpose of compensation. So if this person was working in a company and there is evidence to show that because of working in that particular industry, the vision has dropped. By how much? So by the time you quantify the vision, you'll be able to calculate the compensation, which is why there's this visual acuity rating as a measure of visual acuity that was developed by the American Medical Association. Now, what are the test charts used for assessing vision? Now, most of the charts we use are either based on the Snelling system or the Logma system. So that is an example of the Snelling's visual acuity chart. And then this is the Logma chart, which we have there. This is just comparing the two. But in comparing these two, I will just make one point clear, which is the scoring methods. Now, in the Snelling's chart, if a patient reads a row of letter, say 618, and he gets 1 on the next row, we'll record it as 618 plus 1, isn't it? Isn't it? Is it not? Okay, 618 plus 1. Now, the one he read is on the next row, which is 612 row, right? Now, if another patient reads 66 and gets 1 on the 65 line, you're also going to record it as 66 plus 1. Is it not so? Now, the size of the plus 1 in the 66 level and the plus 1 in the 618 level are not the same size. So we cannot communicate whether the plus 1 there and the plus 1 here, they are not the same. But the Logman chart affords you the opportunity to score every letter. So that if I read the first one, the second one, I got 1 on the next line, the value of that 1 I got on the next line is the same value if I read the last but 1 line and I got 1 in the next line, because every character or every optotype has a score of 0.02. So there is a final scaling. Now, these are some of the examples of the test charts. Now, it is advisable that for the low vision clinic, we use tests based on the Logman system, which is either the early treatment diabetic retinopathy study or the Bailey-Lovey chart, which we have here. Then we also have the Feblu chart, the Sloan's chart, Lear symbol, Cardiff cards, and the CPAC. And these are examples of all this. So now if you look at the Logman chart, oftentimes, if you don't know, suppliers might convince you or confuse you by selling this to you. They look the same, don't they? Look at it. This Sloan's chart and the Logman chart, they look the same. Don't they look the same? But they are not. This one is based on the Logman system, but this is not. So this is the appropriate chart for assessing low vision. And they also have the Femblu chart. The Femblu chart are number charts that are very big. I think the biggest one is about 700 feet. And so you can measure visual acuity. Instead of measuring 2200, which is 200 feet, you can measure 2700. Or if we even reduce the test distance, 10700. So it is quite appropriate also for low vision. And then we have the Lear symbols there. Now, for those of us who have seen the pediatric low vision charts, where they have shape and all those things, it became clear that those things are applicable in the Western world because those objects can be identified in the Western world. There's a ship that is sailing in the water. So for somebody in my village, for instance, who has not seen a ship before, so if he sees a picture of a ship, he will not understand, he won't be able to tell you what it is. But the layer symbols, everybody can know what this is. Okay? If you call it 0, you are correct. If you call it O, you are correct. If you call it a ball, you are correct. So it's just a symbol. Oh, that one, a block, a square, or something. This is a shape of a house. That is an apple. You can call it heart or whatever. So these are just 4 basic symbols that every child, irrespective of your locality, you'll be able to tell what they are. So that is also applicable for children. And it is designed using the Logman system also. Now, the Logman chart, I'll just skip this one and move on to this VA with Logman chart. Now, we talked about the fine scaling by giving credit for every letter read gives more readability. Now, take for instance, when you take your meter rule and you're measuring something that is in meters, and the meter rule is in meters, okay? 1 meter, 2 meters, or you take another one that is in centimeters, and another one that is in millimeters. If you use a millimeter rule to measure a distance, it will be more accurate because the finer you can have 1.1 millimeters. But if it is in centimeters, the jump is going to be there. So the space there will be some error. So the Logman scale gives you that final ability to score, final 0 points, at least up to 2 decimal places, which is more accurate than what we do 6, 6, and so on and so forth. So the strategies for assessing low vision: use large size optotypes, use shorter distance. That's why the Logman chart that we use in low vision, we don't test vision at 6 meters. The low vision clinic is always a 4-meter room. So the test is done at 4 meters. So this is designed to be used for 4 meters, 4 meters, 2 meters, and then at 1 meter. Preferably to use tests based on the Logman system, assess each eye individually, and then you can allow the patient to guess. Okay? Now, when we are testing vision in the regular clinic, you tell the patient, look straight ahead. Is it not? But in low vision clinic, when we are testing vision, we are not looking at how accurately the patient can see straight ahead. So the patient can turn away or use eccentric viewing. He turns the other way and is using some, eccentric point to view. Because what you want to look at is what is the best thing or the clearest thing that this person can see to measure. So you don't have to insist that the patient must look straight ahead. So if it is eccentric fixation, if the patient has to do a head turn, allow the person to do a head turn. And that is why in the low vision clinic, we do not use the projection VA chart for low vision. So assuming you are working in a place and you're developing interest in low vision and your supervisor tells you, okay, go and bring a proposal for setting up a low vision clinic. As part of your items, request for a Logman chart. If you request for projection VA chart, and that thing is brought to me to, okay, please could you advise? I will tell you this person cannot do low vision because we do not use projection charts in low vision clinic. Now the procedure. You measure accurately until threshold is reached. It can be done at 4 meters, 2 meters, and 1 meter, and then you correct for distance. Now I'll just quickly demonstrate this. So this chart is presented at 4 meters, and you ask the patient to read one eye at a time. And so the patient reads maybe this row, and the values are there. This is 1.0, 0.9, so it's dropping in 0.1 steps. Now, assuming the patient read the whole of this first line and could not read beyond that, you score 1.0 logma. Is that okay? Now, if the patient read this line and this second line, this is 0.9 logma. The patient read this second line, and on the third line, read these two. Okay? So, you write 0.9 minus the value of these two. Are we following? Are we following? Now, in Snelling, if the patient read these first two lines, and got to here, it will have been the value of this plus what the patient read in the next row. But using the logman system, it is the value minus what the patient read in the next row. The reason is because the lower the logman score, the better the visual acuity. Is it clear now? The lower the logman score, the better the acuity. So if I do 0.9 plus 0.2, it will be larger. It means that the vision is worse than 0.9. So you subtract the value of these two. And the other thing is, for each optotype has a score of 0.02. So if I write this 1.0, 0.9, and I got these two, it is 0.9 minus these two times 0.02, which will be 0.9 minus 0.04, which will give me a value of 0.86. I agree with me that 0.86 is less than 0.9, but greater than 0.8, which is this next line. So it is a value, so the visual acuity is something between this line and the next line. Is it clear now? Okay. Now it is this clear, but the time taken for the low vision patient is that you may need to take time for the patient to make out the optotype. Okay? So what we just described is what we have here. Each optotype is 0.02 unit, log unit. For every optotype read in the succeeding line, subtract 0.02 units. For example, if the patient read 1, 2, 3 and read UFZ, the value on the row of the UFZ is 0.5. So he read 0.6 and got 3 on the next line. So it is 0.6 minus 3 times 0.02 for each one that the patient read, which will give a value of 0.54 logma. Is that okay? Is it clear now? Good. So that's the first part. So if that test was done at 4 meters, you just record VA, right eye, 0.54 logma. What happens in the case if at 4 meters, the patient is not able to read the first row? What do? You bring the chart to half the test distance to 2 meters. Is that okay? So you bring it to 2 meters. So at 2 meters, you do the test. So if you do the test at 2 meters, and you get your recording, let's just assume, for the purpose of illustration, that at 2 meters, the patient read 0.54 logma, the way we calculated it. What we will do, now, in the Snelling system, we'll write test distance over the size of the letter read. So we'd have written, say, 2 over what the patient read. But in the logman system, what you do is that because you have reduced the distance by half, you add 0.3 to the logman score that you recorded at that distance. Is that okay? Is it clear now? So this person would have recorded, so assuming this test was done at 2 meters and you recorded 0.54, which is what you calculated, you add 0.3 to the 0.54, which will make this one 0.84. That will be the logma score. Now, this chart is a bit truncated, which is starting from 0.8. So assuming I have this chart in my clinic, and I know the largest optotype is 0.8, so once I see a logma score of greater than 0.8, automatically I know that this test was done at a closer distance, which indicates that this person has a worse VA compared to what I can test at 4 meters. Is that okay? Now let's assume that this patient at 2 meters is still not able to read the largest optotype. You are allowed to bring this chart closer to 1 meter. Is that okay? So at 1 meter, you take your visual acuity. Now how do you now calculate? So from 4 to 2, 0.3. From 2 to 1, another 0.3. So if the test was done at 1 meter, you add 0.6 to whatever the patient recorded as a logman score, and that will be the VA of this patient. Is it okay? Is it clear? I guess so. Now, further note, in low vision 2, we move the chart, we don't move the patient. Now, remember that this patient has some impairment, so he may not be able to move around. So you can also, okay, please get up, come close to the chart. So that is why we don't mount, in low vision, we don't mount the chart on the wall. It is usually loose like this, or you can put it on a stand that you can always move towards and away from the patient. So note whether patient constantly loses his place or meets sections of the chart. So when the patient is reading, he reads the chart, gets to half, he can't continue. He goes on to the next line, reads to half, he can't continue. Now that will indicate to you that the patient probably has a feed defect. Or he's reading and he reads, say, up to this point. He reads this through, read that, I read this, probably skip this, and got this. Read that, skip this, and so that will probably indicate that this person has a central scotoma here. So there's a scotoma at the center here, which is why the person is not saying what is there. So you can see that visual acuity assessment gives a lot of information if it is properly undertaken. And now, acquiring the presence of family members, especially when you are testing young children. I don't know what the culture is here. Back home in Nigeria, assuming you are assessing a child. Now, the parents will assume that when you are testing visual acuity, they are doing it as a test. So they want to know whether the patient can read the alphabet. So it is not a test, it is not a reading test. It's not the ability whether he can read the alphabet. So he says, you tell the child to read. The child goes on, arrow, and he's thinking. It's not that he doesn't know what the letter is, but he can't see it. So usually parents say, John, look at that is now can't you see it? And no, you've put fear. So the question is, will the presence of the parent be appropriate at doing the test or not? So that is where you also need you need to be smart. Now, if the patient, the mother, you can ask, okay, please just don't worry. Could you excuse us? Now, the other side to it is, if the parent is there, the parent is not there, and you come in with the child to the examination room. You know, children, when they see anybody with a white coat in the clinic, what is their fear? What is their fear? Syringe. They are afraid of syringe. Oh, doctor, my mother is leaving me. You are taking me away from my mother. Okay? So you also want to consider, should the parent come in? So there is that mix, and which is what makes low vision very interesting. You bring in a whole lot of factors in doing all this. Okay? Now the flip chart. Now the flip chart is simple, just like that. Unlike the logman chart, which is you have 5 in a row, so you just have one character. So it is suitable for assessing visual acuity with some level of comfort because it is easy to handle. It is also more appropriate for bed reading subjects or vision that you can't move them around. So you just take the chart, say to the bedside, and it is based on the logman system. However, there is no need for letter scoring. So you cannot add 0.2 because it's just one letter per page. And so at the smaller level you have 4, you don't score per page. So once the patient can see any one of those 4, that score for that chart, for that page, will be the score. Now, the question is, how do we convert logman to chart? Oftentimes, what I normally do is I have a chart like this that gives me conversion from logman to Snelling in feet. The reason is because when you're calculating your telescopic magnification, it is better done in Snelling. Okay? So if, for instance, a patient saw read 630, and I want this person to read 6.6. Okay? So the telescopic magnification will be 30 divided by 6. That will give me 5x. So if I give this person 5x telescope, chances are that he will read around 6. But here, you cannot find the reciprocal like that. So once you take your VA in logman, you can just use the chart to find the approximate value is Snelling, so you can easily do that calculation, okay? My presentation earlier today, one of the barriers that the respondent also said is that in low vision, there are too many calculations, which is why the idea in teaching low vision these days is to reduce the calculation and make the calculation, keep the calculation in the optics courses. So let's reduce the calculation in low vision to a bearable minimum, because come to think of it, when you are doing refraction, how many times do you have to do calculation, bring a piece of paper and write calculation, divide it and get calculator? And then you are now doing low vision, you now have to start doing log that, find calculator. So it's actually discouraged. So we try to make the calculation as basic as possible. Now, near visual acuity. Once you have tested for distance acuity, you also need to assess near vision. Now, oftentimes we make this mistake. Near visual acuity is not the equivalent of testing distance vision at a shorter distance. You know, when you do Fourier at 6 meters and then Fourier at near. So the Fourier at near is the equivalent of distance. Visual acuity is not the same. Near visual acuity is not a test of threshold. Distant visual acuity is a test of threshold. After this point, you cannot tell the difference apart. Near visual acuity is not a test of threshold. So it's not the near vision equivalent of distance VA. So in the logma chart or the distance acuity, the optotypes are usually the uppercase letters, the capital letters. But for near vision, they are small letters and they are usually reading. Now, there are 3 levels of assessing visual acuity for near. You use the single letter, A, B, C, D, and single, and then reducing in size, of course, small letter. Then use a single word, individual word that doesn't make sense, so you don't have to read. So you just have to identify, give, again, never, tomorrow, yesterday, so let the person just identify. And then there's a continuous test where there is now a sentence. Now, depending on which of these charts you use, they have their own complexities. Oftentimes, when you're assessing near vision, it's a test of reading. And you know that when you are reading, it is not just whether you are seeing it to read, it's also whether you can process that information to make sense of what you are reading. Okay? And these are the things you assess, whether you are using the single letter, the single word, and then the continuous text. So reading also involves altering delivery to reflect meaning and context. Reading comprehension is influenced by reading speed, which is in turn influenced by eye movement control. Now, when you are reading, okay, and this is one drawback of using electronic magnification system, because it magnifies a print so that on the screen probably will see 2 words at a time. So let's say the statement, reading also involves altering. And you're using a magnifier to read that line. And the magnifier at a time will show reading also involves altering, and you are moving the mouse over this. So the words are not continuous. You can make sense out of it because the words are continuous. Okay? But if they are isolated, you may not be able to make sense out of it. So reading, there's a level of cognition to it, which is why when you photocopy some material, it's not so clear. Okay? And you are saying maybe visual acuity. And you write, what is there is visual AC. Without knowing the remaining words, you know that this is visual acuity. So you can make it up and complete what you are reading. So how do we assess near vision? Single letter, single visual acuity. Now the important thing is, when you're assessing near vision, for low vision, you don't insist that the patient must hold the chart at 40 centimeters. Now this is the continuous test, near vision test, also based on the Logman system and using the M unit. Now for low vision, we don't use the N system, we write N5, N6, N7, or N8. Why? Because N5, the size of N5 is not half the size of N10. Is that okay? Whereas this Logman system, the M4M size is twice the size of the 2N. So it is more, the calibration of this one is more accurate. So it is advisable to use the M system card for your visual acuity assessment. So you give this card to the patient. Don't insist that the patient read at 40 centimeters. The patient can bring it this close. Okay? That close. What is important is note where the patient read to and measure this distance. Okay? So you note where the patient read up to and measure the distance at which he read it. I normally record that as, for example, the patient read 3M at a test distance of 8 centimeters. So you record the VA as right VA for near 3M at 8 centimeters. Now this also has implication. Recording near visual acuity like this is very important. One, you can easily convert it to Snelling equivalent. Okay? Now the Snelling equivalent of this, what is Snelling fraction? Test distance over letter size. So the test distance here is 8 centimeters, which is, because you want the two to be at the same unit, this is 0.8 meters over 3 meters, which you can now find the 6 meter equivalent, and then you can have the Snelling equivalent of this near VA. That's one. The second advantage is that it is also very easy from this point to calculate the magnification that is required to achieve a task. So how do we do that? If a patient, for instance, read 3M at 8 centimeters, I want the patient to be able to read 1M, which is the font size for most conventional things, okay? Newspaper and all those regular books that we read, about 1M size. So use simple proportion, and I'm sure from secondary school, all of us can do simple proportion. If 5 people can do a work for 10 days, how long will it take one person to do, right? Okay, so if the patient can read 3M at 8 centimeters, and one is going to read 1M, where will you place this chart for him to read 1M? So by simple proportion, you can calculate that distance. Is that okay? And once you calculate that distance in centimeters, find the dioptric equivalent of that distance, and that will give you the amount of plus power that we require to read the 1M. Okay? So you find that straight while you are doing your visual acuity, you're already calculating and having an idea of the telescopic magnification for distance and the power for the magnifier that you would prescribe. Wow, I think I need to move fast now. We spent so long time in VA. Okay, so visual field. Impaired visual field impairment can affect the low vision patient. For instance, these are what you will see. A diabetic retinopathy will have something like this. So I'm assuming this person is reading a book, a notebook, a textbook. So where these patches are, any print that is there, the patient will not be able to read. Glaucoma, age-related macular degeneration. So all this will affect the reading. So it is very important to assess visual field in patients with low vision. So it's another important visual function test. Peripheral vision you need to assess, and then you also do for central vision. Now, for low vision, autoperimeter is not too appropriate. Because for low vision, you are not looking at the retinal sensitivity, you are not making the diagnosis of glaucoma, but you want to see how the field has contracted. So it is actually better to use the Jerome Targent screen. I said that the Jerome Targent screen is now modified for low vision. It is bigger, the fixation spot is bigger, and the targets used are also bigger for the patient to see. And of course, the Amsler chart, you also will know how to do that. Contrast sensitivity, I'll quickly spend some another time here. Now, what is contrast? Contrast sensitivity describes the ability to detect differences between two illuminants. Now we'll measure visual acuity in the clinic. We are testing vision at 100% contrast, black on white. But in real life, nothing ever, look around here, look at this wall, you can see that the contrast is not 100%. Look at the chairs around, look at the environment. These are not in 100% contrast. So you see a situation whereby you assess visual acuity low vision patient, and you prescribe low vision device, the patient is probably reading 612. And you are happy that, yes, we've made some progress. The patient was reading 660, now it's reading 612, I'm happy. The patient goes home, he's not able to use the device because you did not assess the contrast to know the impact of contrast on the visual functioning. Because at home, in the clinic, you are reading chart at 100% contrast. But at home, things are not in 100% contrast. So it is important for you to assess the patient contrast. So it is it defines the reciprocal of the contrast that can be detected. So why do we need to assess it? It is important for early detection, but that for low vision, because oftentimes before a patient comes to your low vision clinic, the diagnosis has been made. Okay, so we're not doing contrast because we want to use it to make the diagnosis. Rather, the second reason is why we are testing contrast. It will predict significant difficulties in activities of daily living. Driving in the rain, pouring milk in a white cup and all that. And why do we need this information? So that once you are done with the assessment, you can provide additional advice as to how this patient can modify his environment. Now, if you did not test contrast, you may not be able to provide that advice. To tell the patient, okay, if you are eating white rice, you don't place white rice on a white plate because everything will look the same. So put white rice on a green plate so that that contrast difference can enable the patient to see and improve his visual functioning or increase the lighting to make the patient see better. Now, there are different types for charts for testing contrast. These are some of the examples. We have the low contrast Bailey chart. We have pelirrobsin. That's an automated one. And then we have this one. But the one that we're going to quickly discuss is the pelirrobsin and the layer chart. Now, this is the layer contrast sensitivity chart. Very simple. They are based on either optotypes, single optotypes, or the layer symbols. Now, they have charts of different, so changing, flipping, the contrast is reducing, and you'll just have 5 on each row. So this test can be done at a given distance, say at 1 meter, at 2 meters, depending. You can do it at one test distance to just have an idea of the patient contrast. But if you want to plot the patient contrast sensitivity, you do it at 2 different distances. So if you do it at one distance, you just give the chart to the patient, maybe at 1 meter, and the patient reads. You record. Now you can see the values there, 2.5, 5%, and then the values are there, and that is how to score. So if you want to plot once you do, you can record it as follows: layer symbol at 10 meters, the patient read 21 at 1.5 meters. So the test was done at 1.5 meters, and the patient read 21. The chart, they are made up of 25 optotypes. So you just count how many the patient read, and then you write the value there. So that can give you a functional implication of what contrast the patient have. And if you want to plot the contrast sensitivity, you do the test at 2 distances. For instance, you do the test at 10 meters, which is plotted, the number of optotypes read, he read 25 at 10 meters, and at 3 meters, and maybe at 4 meters, which is the point B, he now read 20, which is, because the distance is now more, is reduced. So you can join point C to point A, and you plot the near VA, and then you join those points together. Now, this is the pelirrobsin chart. This very simple chart to use as well. Now, this one, you don't need to plot the chart. It is done at 1 meter, and each optotype scores 0.05 logMAR. So, there are 3 sets. They call them triplets. So that's the first triplet. HSZ is the first triplet, which is equivalent to your Snelling chart of 100%. So it has a score of 0.0. And so you start reading, and the patient reads up to this point. So whatever the patient read to, you calculate for each optotype, you multiply by 0.05, and that will give you the contrast that the patient read. And this is the recording sheet. So you just record for this eye or for that eye. So if I tick here, it means that the patient read 1.65. So read everything up to that point. And for each triplet, if you may got 2 out of the 3, you can score it as correct for them. Now, assessing contrast in children, we can use the hiding AD chart. These are smiling faces, and so you just do them. Okay, there's a clear one, so you put them together and then you split. Okay, and so the patient use the idea of preferential looking. So as you begin to reduce the contrast and bring them out. Once the patient makes the eye movement, it means that the patient say, the patient is not making any eye movement, it means that he's not seeing it, and then you record the contrast, which is also there. You make it, for children, you do it as a game. Color vision assessment, we are getting to the end now. Now again, when we assess color vision in low vision, of course we know that in color vision, there's nothing you can do about in terms of treatment. What you can do is modification and advice. Now we also want to do color vision assessment in low vision so we can advise on how to, the kind of colors we want to be used in the patient's home. Okay? So we can use the Manzoor D15, which we have there. We don't have time to describe that. But because we just want to have an idea, we can use the, now that's either the Ishara is not so appropriate. We can use the Manzoor D15. And then we use the basic colors. So just ask them to recognize any of these colors or this. So any of these ones, you just correct. These are the basic primary colors. And then from that, you know how to recommend for your patient. I think for this last part, I've been rushing, so if there's any question, I'll take any question now. Otherwise, we can call it a day. Thank you. And I thank you for your time. If you have any concern, we can always meet outside of this place. And for the level 9 students, this is what we're going to be doing again in the course of this semester. Thank you very much.